Hello, welcome back. Hopefully you all had a quick break. So we've from Sarah, who's about a paediatric case, and then hopefully we'll have some more questions and answers, and not just about Sarah's presentation, about anything that's come up today or anything that you see in your practice. So do put in the questionnaire in the chat, and we shall get back to you. Over to Sarah. Thank you.
Thank you again, and well done anyone who's still with us. I realise it's after work time now, but perhaps some of you are listening on your drive home. Okay, so this is a talk about a child who presented with profound anemia and the sort of discussion that results in, and makes us think about different ways of handling and supporting someone in this sort of situation. Next, please. Keep going. So this was a girl who actually we were looking after, but Emma had gone to live in Nigeria, having ethnically come from there, but not during her lifetime, but during her parents' lifetime. They decided to go back there, but for various reasons had come back to the UK, but had only literally just got back off the plane to the UK and hadn't actually seen me yet. And she faints and comes to the emergency department, and she's profoundly anemic. Next. So I suppose the questions to everyone, this is more interactive, so sorry if you're all falling asleep, it's a chance for you all to wake up. Can I have some ideas of what your big causes you would think of a child doing this who's just come off the plane? They've got sickle, obviously. Off the plane from Nigeria. Can I have some ideas? Anyone can answer. Pop something in the chat, someone, so I'm not talking to myself. Yep, G6PD could be one. Yep, that's a good one. Sister Banzette, you can keep your job. Who else? Anyone ideas? Perla. Perla thinking either aplasia, Caroline and Ellie, parvovirus. Matty thinks parvo. We've got sequestration in there. And what lovely infection can you get when you're somewhere hot and tropical that can make you quite anemic? Yay, Perla. You too can keep your job. Okay, so let's click through. So the two primary causes, and these are not exclusive, the two big ones that we want to, typhoid. Oh, yes, I know almost nothing about that, apart from I don't want it. The two big causes in sickle cell of profound anemia, not just a bit more anemic than usual, like seriously low, are sequestration and parvovirus. In sequestration, you get pooling of the blood in the liver or spleen. This is one of the children I look after, and it's a beautiful example of splenomegaly in a child who's got sequestration. I did not send them for an MRI, but at the hospital I work in, radiologists get all excited. I sent them for an ultrasound, which would be no fun to show any of you because, I don't know, I can't read what's an ultrasound. It looks like an untuned television to me, but they did an MRI, so I've got a lovely teaching slide, which I've got consent, you'll be glad to hear. So this really shows a very nice big spleen, and what's particularly nice, and I often use this slide for teaching, is that it's very big, but it's not across the abdomen. And we often find that when we have sequestration, it's a big sort of sloppy, juicy spleen rather than a hard, malignant, malaria-infested spleen. So it often does not go across the whole abdomen. It sometimes does, but it quite often doesn't. And if you think about examining, child was about 8 at the time. It's not actually a picture of that child, but the child this picture was about 8 at the time. You would have had to go right across her abdomen and all the way down to the bottom of the left iliac fossa to actually palpate that. And you may well have underappreciated how big that spleen was. Parvovirus, this child, almost an adult now, has given consent for this slide. On account, he doesn't look like that anymore, but that is what slack cheek looks like. If you get the redness in your cheeks, and not everyone does, and also if your skin is a darker colour, then you might not notice it anyhow, but a lot of patients, a lot of people don't get slap cheek when they get slap cheek. They do not get the skin changes. And so 80% of people would have had this infection by adulthood, and you get a real drop in hemoglobin if you've got a hemolytic anemia. So not just sickle. So I've seen a profound one with a child with hereditary spherocytosis. So if your hemoglobin's low already, so you're starting from a lower number, and you are dependent on a high red cell turnover to keep it at that 80 or whatever it normally is, then if your red cells are not produced for 10 days or whatever, which is what happens to everyone in parvovirus, your hemoglobin will drop precipitously. Now, if your hemoglobin was, say, 130 to begin with, and you don't make and you've got normal red cells, and you don't make red cells for 10 days, your hemoglobin drops to what, 120, 110, and your family will say, oh, you're a bit washed out, and you'll say, oh yeah, I had a virus. That's not quite the same as what happens here. So those are the two causes, and of course malaria, particularly if someone's coming from abroad, may well have malaria. Next, please. So how can you tell difference? Examining the patients. Yes, so I've had sequestration present before and not noticed because the child was running around and no one examined him. And reticulocytes are really important. Reticulocytes are early red blood cells, and they will be high in someone who's sequestering or bleeding or hemolyzing, but they tend to be low in parvovirus because you're not making red cells. So those are often with those two pieces of information, you've usually worked out which one it is. Next. So other tests, well, if you've had a recent transfusion, you could be worried about transfusion reactions like I spoke about the last lady. Next. Malaria screen if they've had a recent travel history. And then you probably, if you've got someone who's sick, you want to know that their kidneys are working and their liver hasn't packed up as well. So it's all other useful information. Next, please. So the immediate management is, what are you going to infuse and why? She's a bit clapped out. She's lying in resus in the emergency department with a hemoglobin of 18. So we don't have a voting thing on this in this talk, but can I have some votes for, well, ideas about what you want to give this girl as she lies there in the emergency department, looking a bit clapped out? Perla's voting for blood. What's everyone else think? She wants capital letters blood. She wants packed red cells. She's really adamant it's all in caps. What does everyone else think? Bernadette thinks blood, not fluids. Perla's now laughing. Who else? Cecilia, what do you think? Matty, what would you give? Ruth, fancy pitching in here with your expert knowledge of blood transfusion? Sonia, going for blood. Everyone's going for blood. Well, you are all fabulous. They gave her fluids, and the problem with giving fluids is that it's going to make your hemoglobin even lower. She seemed to survive that, and she did well on blood. So next, she did well. So how much is another question. So there's a really interesting question. When you're transfusing someone in an emergency, what you're trying to do is not make them perfect. You're trying to not make them die. And often the stuff you get in emergency, which we'll talk about in a moment, is not necessarily the perfect product for your patient. Generally speaking, and you need to take each patient as they come. Most people will be all right as long as their hemoglobin is over 40. Most people will be rather well as long as it's over 60. And most people will be relatively, for a hospital inpatient, not for going to work or being at school, will be pretty good over 80. You don't want to, in sequestration, get the hemoglobin too high, because some of that blood actually tips back out into the circulation, and very high hemoglobins are not good in sickle. So I tend to, oh, that's a nice little calculation. Look at you paediatrician Perla, well done. So you probably want to not increment them by more than 40 grams per litre in one go. And that will probably be enough to increase their hemoglobin by a few, a unit, or it depends on the weight of the child, as Perla's very nicely put a nice calculation there. You can use 0.3 or 0.4. Okay, good. So what's next? So you've got blood. Okay, keep going. Keep going. Okay, so, yeah. keep going, just go click through all of these and just then stay on this slide. Okay, so when you're transfusing someone, when you're trying to get blood for a patient, you have sort of 4 options. You can either go the full hog and say, I want everything done. I'm prepared to wait till that sample gets to the laboratory. And I'm prepared to get that blood sample. I'm prepared to wait till they do the group and then do the antibody screen. But you might not have time, and you can't let someone die because you wanted an antibody screen. It's a balance of risk. So there's 2 ways that the laboratory does this, and they decide this and not you. Whether you need an IAT cross-match, which is when they take the plasma from the sample, so the clear stuff with the antibodies in, and match it with a panel of red cells to check there's no antibodies. Sorry, that's the antibody screen. So an IAT cross-match is to take a unit of blood that you think is all right for the patient and take a little bit off it and mix it with the plasma of the patient. Now, in 50% of hospitals that look after patients with sickle, they do not do that if the patient has not got antibodies. They just electronically issue the blood. They say, you've not got an antibody, you've never had an antibody, we know what your blood group is, this is what we're giving you. And that's called electronic issue. And that can only be done in situations with very, very high regulation in the laboratory, because you haven't actually physically cross-matched it. So the laboratory will have their own protocols for doing that, and it will also depend if the patient's ever had antibodies before. For this child, she got group-specific blood because they said they could get it in 5 minutes, and she was sitting up and talking. So that means I knew she was, say, blood group O, little r, and that's what they gave me. And that's what she got. Flying squad is you take what's at the end of the bed in the fridge, which will be in resus or somewhere in the emergency department. So flying squad blood sits in places where patients either present profoundly anemic or bleed all over the shop. So that blood will be available in emergency departments, theatres, ITU, and in labour ward. And in labour ward, they have units for the baby and units for the mother. But it's not as well matched as actually getting group specific for your patients. So it depends where your lab is. It depends how easy it is to get it to you. If you've got, like we have, electronic fridges, you can speak to the lab to let a unit out for you that you want, because there's a range of units in there that aren't specifically for a person. So it might take the same amount of time. Using group-specific blood is a consultant decision, or registrar, I think registrar in haematology can make that decision. Flying squad, anyone can go and get it who's trained in blood transfusion. So you shouldn't wait too long. Don't worry, perfection is not what you want here. You want to make sure that your patient's safe. Okay, so moving on. Yeah, so the question is next is splenectomy. So this kid is 13 and she wants to go and back to Nigeria. And this is her 2nd sequestration. What are your thoughts around splenectomy? Sonia, what do you reckon? Or Cecilia? No, they weren't on disease-modifying treatment at this stage. This was a person who hadn't really had. Oh no, she didn't take it. She'd been offered it, and then they didn't take it. She didn't want to take it. You know this girl. She ended up having allograft in America. Okay, so clicking through, please. So she's quite old. She's not going to auto-infarct now. She's had 2 sequestrations. One had happened in Nigeria, which I hadn't realised. And understand relative risk. If you're in Nigeria, you might not have access to blood. Often you can get a unit of blood if someone else donates in your honour. And then there's less screening done of blood products vis-a-vis infection and blood grouping. So you've got different risks because of what she's deciding to do with her life and where she's deciding to live. But splenectomy is not without its risks, and we do mostly very well, but occasionally things happen that aren't good. And so those kind of risks need to be discussed with the family. Hydroxycarbamide is an interesting one. I think there was often a bias to say that children who had sequestration, if you gave them hydroxycarbamide, that would increase the fetal hemoglobin and prevent autoinfarction. In reality, that doesn't happen. A lot of our children now do not get autoinfarction, and I think we probably at some point will need to revisit the penicillin discussion. But especially with all the vaccinations that are around now that weren't available when people did those initial studies in Jamaica. But aside from that, a lot of our patients are not hyposplenic, especially if they've been on hydroxycarbamide for a long time. So this child did have a splenectomy because they're just adamant, the family was adamant to go back to Nigeria, spend some more time then. It was balance of risk in her, and she didn't really want to take hydroxycarbamide. I think that's it. You want to see? Click. Don't click. Please click. And that's it. Okay, any questions that arise from that?
So there's nothing in the chat. What happened with her?
What happened in the end? Sorry. Yes.
She had a splenectomy,
Yeah.
but she had sort of grumbly bad sickle, not terrible sickle, bad, but it was really affecting her. And then she just wouldn't get on with hydroxyurea, and she just wanted to be cured and went for an allograft in the States. You remember who it is, without saying any names.
Yeah.
Yes.
It was a mud as well, wasn't it? Because the brother wasn't a match.
Oh yes, from the aunt.
Was it a haplo then?
I think so.
Anyhow, not a match SIB. So a very high risk procedure. Okay,
it's a dilemma. It's always a dilemma, isn't it, when you have a child with recurrent sequestrations, splenic sequestration.
And she was Gillick competent. She was very much part of these discussions, but I don't know that she was a bit of an angry teenager, and I don't know how much she was always voicing her best interests.
And do you know why? What was the main problem about hydroxyurea? How did she express her?
Didn't want to take it.
But did she give any specific? I mean,
well,
she wanted an operation, but she wanted an operation associated with potentially, huge risks, but didn't want hydroxyurea. Did she express why?
I think Ruth and Matty can probably chime in here, but there's something about doing something every day that is a constant reminder of the health condition you have. And with the Twitch study, where children with raised TCDs who've got normal MRIs, who've had 18 months of transfusion, can switch on to hydroxyurea now. None of them take it. They'd rather pitch up once every 5 to 6 weeks and take another medicine every day. It's really interesting. What do you think, Matty, about all of that? What's your experience of?
I do totally agree. I think a lot of people would rather just come to the hospital, have the blood and go home, because A, they don't want to be reminded and have to take the tablet all the time, show that they're different from everybody else. And then sometimes it's like a lot of responsibility and pressure, and they just don't want it at all. I've lots of people that you can't even mention the word hydroxycarbamide to them, even though it would be better for them.
I always find that quite striking, isn't it? Because when you see someone in a crisis and how absolutely awful it must be for them, and you just think, just take a pill every day. Why isn't that easy? And yet still,
you would expect to be able to convince them, yes. And
in my experience, people have spoken a lot about the different side effects that they feel that they get from the medication, and it could be to do with their hair or their nails and things like that. And it's very important, I guess as a teenager, how you look and how you're perceived, and it's quite a big ask perhaps to take something like that every day, if you are getting these side effects which feel that they're impacting on your quality of life in other ways.
And there are many disbeliefs and myths about hydroxyurea circulating, amongst patients and passed on from patient to patient, about side effects which have been reported but never been really proven. And I think that's one of the other reasons that a lot of patients are hesitant to take it. So I think it's not just a matter, I think it's a matter of, you know, compliance, or asking a pill every day. So as a general, if you look at it generally, so it's the difficulty of every day and accepting that they have a chronic disease, but also what Ruth just said, plus the dispute hydroxyurea. So it's a combination of things. But I was wondering whether this particular patient expressed any particular reason, or whether they just said, because sometimes they do it, they say, no, I don't want to have hydroxyurea, full stop. I don't need to explain to you why not.
I don't think she had a particular reason. I think she just didn't really want to do it. And her parent was back in Nigeria pushing for the transplant, wasn't she? Her mum was very, very keen for it and happy to pay for it. And they just wanted a cure. And I think that was the...
We do sometimes see that, don't we? You just want the problem to go away, and I can understand why. It's very different when you've got the perspective of having seen lots of patients go through those kind of treatments and some don't make it. You just think, you know, so our view is slightly different.
Yeah, I think sometimes it actually helps to come from their peer group as well, because sometimes it's like somebody that's actually taking it and has been taking it for a long time, they've got a different perspective on how it affects them. And so I think sometimes it really helps patients to actually hear it from somebody else who's been through it and who is taking it. So sometimes I do hold hydroxyurea tea parties, and just as an information giving for people that potentially could come onto hydroxycarbamide, and they just hear it from a few of the older patients who've been taking it for 20 years also. So that sometimes helps, rather than coming from me who's never taken it before.
Yeah, it has that peer group support, has that authenticity about it that however much we try, we don't quite have, because unless you've walked in the shoes, you don't quite, you know, you can have a lot of insight, but it's not quite the same as having been on that journey yourself.
Yeah, it has a different kind of power if you hear it from your, you know, doctor that you see once every, you know, a few months, as opposed to, or maybe in addition to hearing it from your peers. I think it's an additive power almost, rather than just hearing it from your doctors. But every patient is so different, isn't it? I mean, there are some patients who are very receptive to it.
Matty, when you hold the hydroxyurea tea parties, do the people you invite along, are they all very pro hydroxycarbamide, or do you have somebody on the other side of the fence as well?
Well, no, usually I have my pro group, and then the ones that potentially it's been mentioned that they should think about hydroxyurea and given information to find out more about hydroxyurea. So sometimes you get some of those that are very anti, because they've obviously heard things from other people or looked things up on the internet. So they all come with their own ideals and thoughts. So yeah, so it is more of a conversation. But yeah, no, it's usually very productive.
And let's not forget again, that the exciting treatment is coming up. So soon we're going to have than just hydroxyurea. I mean, I'm a great fan of hydroxyurea. It changes lives, but still some patients cannot have it for various reasons, or don't want to have it, as we just said. So there will be other options. And there are
I think also, I think often the adults, we start too little too late, and it doesn't have the benefit that I often see in the children. But a lot of the children, it's absolutely transformative. I've got probably a couple of them where it's just not enough. And I am hoping that as GBT comes through, and it's the very hemolytic kids, that it's just not quite enough.
But yes,
some of them are transitioning, can't remember their crisis ever. So you're trying to do this transition work at sort of 17 to get them into the adult service, to say, do you know what to do? How would you recognise a crisis? And I've got no idea. I can't remember ever having one. And with SS, who were, you know, sick as little toddlers, been on hydroxy since, and just have no recollection of, thank goodness, of what that would feel like. So, Bernadette, is it almost going home time? What do you think?
And there's been no questions come in, so I think we can come to a close. If anything comes up, or you think of any questions, you can email us. Ahead of today, so there's one focused on nursing and one focused on upcoming treatments and a bit more.
Have a look at those in your own time. And Amina will send out the evaluation at some point next week. If you can all
Please do it, and then once you've returned it, we'll send out your certificates for you. Thank you very much, everybody.